guys, so we're going to get started tonight. If everybody could, I will. If everybody could, please silence your cell phone out of courtesy. So tonight, guys, in us doing our Survey Monkeys that you've been helping us out with, guys, a lot of very positive things, a lot of very rude things, but sometimes that's just what those surveys detail. And that's okay, that's how we learn. But in doing that, we've been asked a lot of different things. Hey, can we try a case review this way? Can we try a case review that way? And that's what we want is your input so we know different ways so we can try to learn. And it gives us a lot of different avenues. So we'll still do some of the big educations like we do with cases. But tonight we've actually pulled 4 cases. And Dr. Troutman's going to run case review and kind of go through those cases with the medic. Now, we'll always, remember, we'll always praise in public and we'll discipline in private. So everything pulled tonight is for a very positive thing, very good learning experiences. The crews have done a great job on these calls, and so we want to talk about those things. But we'll never bring anybody up here and discipline in front of everybody. That's not a good practice, and that's not what we want to do.
It's M&M, right?
Yeah, that's M&M. Those are on every other Tuesday or every other Friday of the month. And if you want to go be a part of that, you can have at it. So tonight, and guys, if you'll notice, we broke it down a little bit more on your state certifications and your NREMT. I'm going to start breaking it down a lot more specifically to help you guys out because on the state stuff and the NR stuff, it does get a little hairy with some of the new regulations we have, and so I need to define that a little bit better for everybody. Also, for all of you NR folks, I am now putting those CEs in for you in National Registry. So those are being filed for you. They're already in your queue. You'll just be able to go in and pick those. So if you attended or you did, I ran it go off the roster, then it's already going to be put in your NR for you. So hopefully that'll make that process a lot easier than all of you doing it, just one of us doing it. Okay? Any questions on NR state stuff? Okay, so we're going to get started and move forward tonight. So we have a case on CVA. We have a respiratory. We have a trauma, a spinal mobilization, a burn, a cric, and a spinal mobilization. Okay. So the first case tonight that we're going to be going over is the stroke, but the medic is on his way from out of town, so we're going to skip forward to the next one real quick. I apologize for that. Okay, so we're going to talk, Nick, you're going to be up first, boss. You get to lead it off now. Spencer was supposed to break the ice for you, but he didn't.
Have you been here since we've done one like this? We used to do them all like this.
Yeah.
Essentially, you come get the setup here. It's no big deal. And I've got it if you don't have your report. Do we need to use the microphones?
Yeah.
Okay. You get to use the microphone.
So basically, if you'll just kind of walk through that call and tell everybody about your call.
So this is here if you need to reference anything.
All right. Just
kind of tell us about the call.
this was a female house fire pulled out by a little fire. I believe the reason they got the call was a mailman found smoke coming out of the mail slot. So when they got there, they found her unresponsive, laying in ashes. There was no actual flame, but she had a lot of smoke inhalation injury. When we first found her outside the home, there were no apparent burns, but there was soot all over her body, no actual injury that we could see. So we got her into the truck immediately, and we called for a second truck because we weren't sure if there were more people in the house. And when we got her in the truck, we started to look at her airway and noticed that she was swelling very rapidly. And about the same time we got her in the truck, the second truck got there, and we asked for their assistance to help us get her intubated. She was unresponsive, but she would groan and moan every now and again, but it wasn't really painful stimuli. And she was, if you did try to open her jaw, she would fight. So we did knock her down, and we had one attempt with the King Vision. We inserted the King Vision. We could see her cords. There were notable soot marks all over her cords, everywhere in her nasal airways, and we tried to pass the tube. Like I said, they were visible, but as we started to insert the tube, we couldn't get it close enough to the cords because of all the edema and swelling in her upper airways. So her tongue was starting to swell, everything around her cheeks, and so it kept knocking the tube out of the way. So we would hit the vocal cords, but we couldn't get it manipulated enough to get it through to pass. We did try to get a bougie inside, and that was even more difficult, because by the time we put the bougie in, she was swelling even more. So we had one attempt, basically, and even then, I mean, it was a very difficult attempt. At that point, she started to break down, and we noticed that her oxygen saturation was starting to fall, although we weren't really sure how accurate it was because she'd been in the fire for a really long time. We don't know how long she'd been there. Later, after the call, we found out that her body actually smothered the fire out. So she was right on top of it. At that time, we decided that we needed a criker. So myself and the 2 other medics over there certainly did that. One did the incision, one of us used the hook, and the other used the spreaders to insert the tube. It went pretty well at first, and then we weren't sure. We got good compliance after we did some adjusting. We got it in, got it set. At the same time that we got the tube, though, she did go into cardiac arrest. And at that point, I think that was primarily because she'd been without oxygen for so long. And I mean, it was, from the way that we looked at it, it was pretty inevitable. I mean, she was at that point anyway. I don't think there was much that we could have done for her other than criker. I mean, it happened pretty quickly. I don't know how soon we criked her from the time we got on scene to the time we actually did it, but it was pretty quick.
About 7 minutes.
7 minutes. So we put in the tube, and at first we thought that we weren't in because we started to have some difficulty with compliance, and at the same time we noted that she had a lot of swelling and what looked like sub-Q air all over her neck. Her face started to completely swell, so we thought there was some sort of occlusion to the tube or something in the airway that we thought that maybe we had missed. Well, as we repositioned it, we got the airway back in and started bagged with good compliance, and later we found out that she had so much hot air in her lungs, it just helped release it all, and so she was still burning internally. It was just all inhalation injury. So that's where all that swelling came from. It ended up not being sub-Q air, but just edema from being burned.
Do you remember how your capnography looked?
I don't remember how it looked, actually. I know we put it on and we had a hard time getting it to read, and I can't remember why that was, but we put it on, we bagged with good compliance, and we're not sure. I know the trauma surgeon said that initially the tube was up against the trachea, and when we adjusted it, she could see how we did it. And so we're not sure if we had bad compliance because of the blood. There's a lot of blood, so I don't know if that was just occluding something or if there was still a lot of soot in the airway that was giving us a bad reading. But we tried one capnography and we switched out to a different one to see if it was something wrong with that specific one, but we never got a good waveform long enough to see what it was accurately.
Right. And then so she started coding, y'all ACLS to the hospital and delivered.
We did.
Or did y'all get her back before we got to the hospital?
I think our transport time was 6 minutes, so we did one round, and then we looked and she was still asystolic, so we did a second round, gave her some epi, and then by the time we got to the hospital, we were still doing CPR, so we were at the point that we weren't having a pulse check.
Right.
When we got into the ER, she was in a systole, but they got her back pretty quickly. The trauma surgeon actually went in and redid our cut and put in a larger tube. I think she put in a 7.0, and we initially did a 6.0, if I remember correctly.
All right, I think that's a great recap. I'm going to steal that just because I had some notes in here. So it's a fun case, isn't it? Probably a little nerve-wracking, but those are the cases at the end of the day you kind of like to be on. Did a great procedure. Was that your 10th cry
It was
run? Or?
number 11, I think. Yeah.
That was your first one, right?
Yeah.
Right. How many people in here have done a cric on a patient in the field, not in a cadaver lab? Not very many. I haven't. So those were 7 or 8. So it's a rare thing to do, but it can be life-saving whenever we do it. So, and I think everything is written up great and all that. Go to the post-care before we go to that. Was that actually after this? So this is what I really wanted to talk a little bit about here. So the patient came in, obviously was very sick. We got an airway, had some difficulties with the cric, but I think we were getting some oxygenation in. came in the trauma bay and was revived pretty soon after. Ended up with a stay, of course, in the SICU. Was pretty sick. You see, you have a pH of 6.5. That's pretty darn low. Had some anemia, got some blood. Had a relatively uneventful stay, just like a week or two. Ended up with the tube out and went home. But I mean, I think we definitely saved her life for sure. So we can go back to that slide before. So, what was our total on scene time? It was
About 19 minutes total.
yeah. So, at first look, well, this is a trauma, that's too long, but hey, we didn't want to be doing a crank in the back of the truck. We recognized we need to get an airway secured to this patient, and A is the first thing, right? So we're not going to flub over or fuss over somebody being delayed on scene trying to get an airway that proved to be a very difficult airway. So I think delayed scene time was very appropriate. The capnography. So, why weren't we getting readings? You said you changed out, that was great. But imagine what's this patient been breathing? Smoke and carbon monoxide and all the other crap that goes in with that. Now some of that's expelling back off. Those meters are very sensitive. You even just have somebody kind of vomit, get some vomit in the tube or something, they quit working. So with all that smoke and stuff coming back out, most burn patients, you're not going to get a good capnography at all. So I wasn't surprised at all. And I think also the crew did a good job on not just going, crap, we don't have capnography, let's just yank that and try something else. We looked at, mentioned compliance. I think there was mention the port was listening, heard some breath sounds. So we went to those other adjuncts. Remember, capnography is not the only way we recognize tube placements. It's a great way, but when one fails, use those other tools. So we did a good job on using the other tools and recognizing, well, I'm not getting capnography, but at the end of the day, I'm convinced we're oxygenating the lungs, and we went with it. So the other thing we didn't talk about, but we did do an IO. Really, there was any complication she had. This wasn't too big a deal. She did have a pretty bad cellulitis and stuff over that site. Whenever we're placing IO, and I can imagine this being a stressful situation, I don't know how well the site was cleaned. Technically we do need to clean it pretty well. My understanding, the patient was very black and sooty, and everybody's gloves were black and sooty, and probably the site may not have been prepped. It may have been prepped excellent. Even if you prep things excellent, you can still get infection. So it's not a huge deal. IO site infection rates pretty low, but certainly somebody like this that had gross contamination, we certainly probably added to that. But my understanding also is that on follow-up that infection was improved, but that did develop a few days into the ICU stay, that she had this pretty bad lower extremity cellulitis that was attributed to the IO. So overall, great case, and guys did a great job and saved her life for sure. Anybody have any questions?
Could you touch real quick on why y'all decided to use the Northuron on the PAI?
She had when we first got in the truck, my partner went to grab a blood pressure, and we noticed immediately she had a shunt in the left upper arm. So we assumed that she was a renal patient. And then the fact that she was a burn patient, I know that you can, I guess, there's some use sucks early on, but we went ahead and just used it. The other thing was, seeing her airway, I wasn't sure how quickly we were going to be able to secure the tube with her swelling. So we needed to keep her down for a long time.
And those are good thought processes to have in very stressful situation. You're going to have to be doing a lot, and they were still able to think through that and go, okay, I know I've got to give. Now, if they would have given sucks here not knowing it was a renal patient, so be it. They can dialyze them a few days later. But we sure need to do our due diligence, and the crew did a great job here by thinking about those whole processes. And Nick and I have had a conversation before tonight, and that's why I asked him, especially talking about that prolonged paralyzation that was going to be needed for what was being done in the truck.
Yeah, so the concern is that succinylcholine has this theoretical that it increases potassium. So of course, dialysis patients, they have a tendency of having higher concentration of potassium depending on where they are on needing dialysis or if they miss dialysis. And then when you have a subacute burn, and it's usually somebody that's in the burn ICU that's been up there 6 days and they deteriorate, just and I couldn't tell you what the physiology is behind it, but with a significant burn, they tend to have elevated potassium. So when you use succinylcholine on that person, there's also this idea that the potassium may increase. Now, a lot of people say this is really not a concern. You can give sucks to everybody, and it's not really worrisome. I think this was great that the crew picked up on that. I certainly wouldn't fuss over, even if you failed to notice a dialysis fistula and went ahead and gave sucks. Patients at the dialysis center, and we tubed them, and you use sucks, we might kind of question, okay, you're at the dialysis center, they probably were on dialysis, right? So it's not a huge deal, but appropriate way you all went. Cool. Any other questions?
One thing, I'm sorry, a great job, by the way. So one thing I'd like to point out is just to remember, he was talking about how the airway was swelling extremely fast. Well, think about that when you're putting in a cryoc also. Your tube can get dislodged very easily. And this used to happen all the time when I worked in the burn ICU, because we get in a new patient that was brought in, that was just intubated, and they do a tracheostomy or something, but the swelling still is going on. That tube can sometimes they blow up 3 or 4 times the regular size. That tube will just pull right on out of there. So, as you're going along, if you have an extra long transport, 10 to 20 minutes, just keep in mind that tube may dislodge. So keep in mind of that.
Well, one of the factors too that I was also curious about afterwards. I mean, she was in arrest at the time after the tube, but she had sickle cell anemia, the obvious CO, and being in arrest, and we had a hard time getting our pulse oximetry up. So with those 2 conditions, how reliable is that at that point anyway?
There's probably a good chance we may have just had problems with her oxygenation just because she wasn't having good gas exchange in her lungs. And this person, later what we found out, they started a fire and essentially stayed over to try to kill themselves. So they got a lot of heat injury and a lot of inhalation injury into those lungs. Those lungs were pretty sick. The patient was fairly young, and that's why I think she bounced back pretty well. So probably even, there's always a question, well, did she have soot on her hand and we were just not getting a good reading? That would have been the best we could get, even if we fiber optically knew that we were in the right place and giving great oxygen. Maybe 79 is as good as it's going to get because we're just not getting good gas exchange. And that's certainly a possible explanation. Cool. All right, we'll move on to the next case. All right, thanks.
We got sent to this guy's house. We were from the station to this guy's house. We responded with Chad and Donnie. They were in the Fox truck together and arrived before us. We got there. It was just for a fall. No big deal. We got there. The fire department was already on scene. They were back in the backyard with the patient. He was between like a arboretum and the side fence. They bent down and talked to him. And they said that he was acting fine. He was able to answer all questions, and he denied any pain. He just asked for help up off the ground. It's kind of wet where he was. This neighbor sprinkler was spraying on him. They got him up out of that, and they sat him on his walker. He began to act like just acted strange. Just something was wrong, and he just started leaning left. Big time facial droop to the left-hand side. That's when all 3 of us were around like, this is probably not an N6 with vitals. So Donnie went to the truck and activated the stroke team. We got him put in the truck. Pulled him out into the truck. We transported immediately. Started 2 IVs on the way to the hospital. He was very bradycardic and had a very low blood pressure. I can't remember what the first one was, but it was pretty low.
Yeah, it was
like 64 palpated or something. And the heart rate was in the 40s. It was just a sinus brady. It wasn't a 3rd-degree block or 2nd-degree block or anything. It was just a pretty sinus brady on there. So we started both IVs. We had our report called. We updated the hospital of our vital signs, and I called and asked Dr. Chin, that's who I got on the radio, if they wanted us to go ahead and administer the atropine with the sinus brady or withhold due to the positive stroke scale. They went ahead and gave us the orders. For the 0.5 atropine, we saw a positive increase in heart rate and blood pressure. Throughout the call, the patient just deteriorated. His level of consciousness became where he couldn't speak at all. Had big time left lean. His pupils were all over the place. He was declining quickly. Got him to the hospital and took him straight to CT. Didn't show anything on the CT, I don't believe. But that's about all that happened.
Cool. All right, good job. Yeah, that sounded like a great recap and exactly what I got whenever I read the report. So did a great job recording all that. What are you circling, Chad? It's like a buzzard.
Oh, sorry. It's better to be on you.
Was that about the
Just that acting, calling for orders?
Yeah, and which it sounded like they were kind of call and report and just, hey, by the way, you know, obviously it gets complicated because we're recognizing, hey, this person I'm pretty sure is having a stroke or bleed, having some sort of neurological event, but their blood pressure is low and their pulse rate's low. Do I give them atropine? Do I pace them? You know, because you could argue, well, they're altered, so should we pace them? I think the right answer, though, was to give the atropine because, you know, there's kind of altered, but then there's the stroke altered, and y'all were seeing definite kind of one-sided issues and things, and that was all kind of changing in front of your eyes. So I think giving the atropine was probably the best idea, and not going to pacing in this patient. Let's go to the 7-minute stroke, or the 7-minute time on scene, obviously huge. Remember, we want to get these patients to TPA within 3 hours of onset. So our onset here was pretty quick. We're assuming when they kind of fell down, so, you know, we were 30 minutes or so by the time we got to the hospital at most. So, you know, we want to limit those scene times to less than 10 minutes, again, so we get them, and we have that 3-hour window to give the TPA. So everybody knows what TPA is, tissue plasminogen factor clot buster. It essentially goes in and tries to bust up the clot so that blood flow can return the distal part or the part past that to the brain. The reason why we go for the less than 3 hours, you know, what happens if you put a tourniquet on your arm? It starts turning blue, right? It starts dying. If you leave that on for 2 days, what's up? Your arm's dead. Well, the same thing's happening in your brain. Just think it's a tourniquet. So if you block off a blood vessel, the brain matter past that, distal that, starts dying. So less than 3 hours, we have a little better chance of not only getting life back in that brain, but also at some point if we return blood flow, the blood goes in and goes out, and we end up with a hemorrhage. So that's why we don't usually get TPA 6, 7, 8, or further hours out. Elevate the head of stretcher. Again, we're trying to worry about ICP. And if we do intubate and we can control that end tidals, we want to go that 35 to 45, you know, the blood pressure. So we want to keep it above 90. We don't want it too high. So the idea is when the blood pressure is too low, then you're not perfusing other parts of the brain, potentially. As that clot's in there, the brain's going to start to swell. And especially like in this guy, the blood pressure is 60s, 70s, you're not getting as good a blood flow to even the rest of the good brain. So as we bring that up, it allows the blood flow a little bit better in. And of course, oxygenation goes without saying. So let's go to the follow-up on this one. So did have a right, I think it was a right?
Right frontal.
Yes. Yeah, so it's the middle cerebral MCA. That's a real common, you'll hear, you know, I don't know if I could quote it, that's the most common stroke, but if it's not the most common, it's within the top 3 that gets that right frontal lobe area. So the patient was a candidate for TPA and did give some improvement. You know, remember, TPA is not always the magic bullet. We don't give TPA and they don't always get back 100%. Sometimes they do, but the idea is if we get some function back, it's better than not getting any function back. It sounded like he did get a second infarctus later. What else is in here? So I guess ultimately he went home, wasn't the best, but had some left-sided chronic weakness. So it wasn't a miracle case, but...
Now, to say some of this, Spencer did a great job documenting because this gentleman had a previous CVA.
And so that made it very hard for us to size him up for are we active now, are we active later? You want to visit a little bit about how you determined that versus new versus old?
When we originally got on scene, the guy was outside raking leaves. I mean, it's not like he had just wandered outside and had fallen down. I mean, he was out there doing yard work when this started. So he obviously had some motor function before that. Was able to stand and use a rake on his own. So we talked to the wife or the caregiver who was there, and she wasn't very willing to give information like a lot of them are. And she finally told us, no, this is not how he normally is. And I asked her, is this how he normally speaks? And she says, no, this is not his normal. This is not how he normally acts. And that's how we determined that it was acute rather than old.
And I mean, that's always good information too, because, you know, we could have been, you know, if we wouldn't have garnered all that information on scene, the next thing you know, you show up to the hospital and we're, you know, well, did anybody at the scene say anything? I don't know, he was laying out in the yard and couldn't talk. And so what do? We go start looking through the medical record. Well, this guy had a stroke 2 years ago, so, you know, he probably wandered out there and fell down, so we're not going to do anything. So, you know, garnering that information, time of onset's huge, some sort of baseline and past medical history can be instrumental on TPA or not.
And I truly feel after visiting with, and I sit on the stroke committee, after visiting with Sarah and the physician, they really feel that this patient had big improvement from the TPA because of Spencer's report. He did a nice job documenting that, yes, there was an old stroke, but we have new symptoms today, very accurate with his timing as best as he could be, and actually put a time in the report, which is huge for those folks. Therefore, he could receive the TPA and get as much improvement as possible. So these folks are looking at these, and they're really leaning on what our EMS documentation is, and Spencer did a very nice job documenting that and sorting through. That was the number one question was this the old stroke or the new stroke? And so that we're able to buy him that TPA therapy and give him some improvements in his quality of life. So great job.
Well, Bash, this, what do you think about giving a TPA in the field for stroke? That was a scary thought, isn't it? Do you think anybody's doing that in the country? For stroke?
I think so.
So UT...
TXA or
Yeah, you're talking about TXA. That's the only folks that I know that's even kind of playing with it, because really you need a CAT scan. I haven't seen one in an aircraft yet, but there is a CAT scan in an ambulance down in Houston. That, you know, it's early stages, but I think they have utilized it at times. Now I've seen the unit. I mean, it's this like armor-plated ambulance that's going to all be lead covered, so you're not at a stoplight, you know, exposing everybody to all the gamma rays or whatever. But you literally open the door, and there's a donut in there and a little table, just kind of a little miniature CAT scan. It's just big enough to CT, just a little CT ahead. But that way, then they can do that, you know, decide it's not a brain, or decide it's not a bleed. Obviously, we hope there's a brain in there. And then make that decision on to get TPA or not and get it rolling before you even show up to the hospital. So who knows if something like that ever comes mainstream. You know, that one ambulance, I can't imagine what it would cost. $3-4 million. Can we buy one of those, Chris?
Yeah.
Next year.
All right, thank you.
Good job, Spencer.
All right. We were called to residents where we found a 74-year-old female patient in obvious respiratory distress. LFD was on scene, had just put her on NRB. They said they found her sats at about, I think it was 88% or 78%. She's in a tripod position. She can't speak. She has retractions noted, very sweaty. Wheezy noted in all lung fields. We immediately went to a CPAP with a dual neb. Quickly got her to the truck. And once we got her in the truck, she's obviously very tired. Her SATs have came up with the CPAP into the 90s. But her respiratory distress continued. She still had retractions. She was very, very tired. And so we opted to go ahead and knock her down. We got the line going. We got the drugs ready. Went ahead and intubated her first attempt. Everything was successful. Got the good end titles, good exchange, good SATs. Gave the maintenance dose of Versed and fentanyl. Then we started having problems with her bucking the tube. Gave her another maintenance of Versed. She continued to buck the tube. Vitals were really good. We monitored throughout. Called for orders for more Versed. Once we got to the hospital, that third dose of Versed just bottomed her out. But we were happened to be at the hospital at the time. So,
Perfect, yeah, no, I think well-written report and excellent care. We wanted to kind of talk about this case a little bit because we've been pushing CPAP and talking about preventing intubation. We've talked about why, it's less hospital-associated pneumonias, but we can't prevent them all, right? So this was, I think, very appropriately, we got that CPAP on pretty darn quickly. It looked like within a minute or less when y'all got there, you were throwing them on the CPAP. They'd already been on the non-rebreather. We weren't getting anywhere with that. So we got them right on the CPAP, spent a few minutes on it. We noticed, okay, well, we're fixing our oxygen numbers, which is good. But remember, that's not the only thing we're caring about, right? How's the patient feeling? They're still struggling. They're still very tachypnic from the numbers in here. So we recognized, okay, well, our numbers look better, but the patient doesn't look better, so let's intubate. And we did, and it was the right answer. So I think we kind of covered that. I forget, did y'all use nasal cannula oxygenation during?
yes.
Yeah. So, and I know we've kind of talked about that, and I do that now anytime I intubate. So just remember, whenever you're before you knock somebody down to tube them, just put a little nasal cannula on, hook it, turn it up to 8-10 liters, and it just gives some of that passive oxygenation. Not to be confused with the passive oxygenation we are using in medical codes, but it's kind of the same principle. There's just some of it's going to go down into the lungs, and if you're having a difficult airway, maybe it buys you another 20-30 seconds of them not going hypoxic. That may be enough time for you to make the adjustment. Ooh, I see cords now. Let me get that tube in. So it's easy to do. Since I've been doing that, I've tried to intentionally wait as long as I can, and I don't even see the SAS drop. And some people, I think some of the reports or talks I've seen, they talked about people going 10 minutes without desatting, just having a high flow nasal cannula. So that's pretty cool. And continue to do duonebs. Even once you have an endotracheal tube in, we can do inline duonebs, right? So we can continue to get those in, kind of bag them in. This one, we don't have any follow-up on this one because they were the...
Yeah.
Right. So cool. Any questions? No? Great case, great job. Thank you.
38.
This was, we got called a motor vehicle accident, car versus like a rental dumpster. When we got there, we noticed that the dumpster had been displaced approximately 20 feet or so. Bystander stated that the driver took off, and what was left was this roughly 100-pound, 30-year-old female. Very agitated. She had the extrapyramidal movements where she was tweaking. She was tweaking, and she admitted to methamphetamine use. Stated that she had some alcohol, I think, and possibly some other drugs. She was alert and oriented, and I went ahead and we didn't clear her C-spine just because of the nature of the accident and her intoxication. So we went ahead and put her C-collar and boarded her. It was going to be my partner's patient. It was BLS. We backboarded her. Vitals were stable. And I got out of the truck to go drive, and when I came around, the police department was clearing a weapon that they'd found in the front seat just right under the patient. Just from where we were sitting, she was kind of leaned into the car on the passenger front and very agitated, just moving around, trying to find stuff, saying that she needed her purse and needed this and needed that. They asked her about weapons. We asked her about weapons, and she denied any in the vehicle. The cop asked if he could have a discussion with her, and we got in the back of the truck, and he determined that she knew about the weapon and he was going to take her into custody. They put her in handcuffs while she was on the backboard, cuffed her to the stretcher, and at that time she became very agitated. while she was in the truck, she was very thin, very frail. She became very, very agitated, wouldn't calm down. So we decided to put her on the monitor. Her heart rate jumped from, it was initially like 90 to 100, and now it was 140 or so. We questioned her about synthetic use, and she really wasn't sure what she'd smoked. We gave her a little bit of Ativan, and it seemed to calm her down a little bit, but she was still pretty agitated, probably more so due to the arrest and finding her dope.
Do you think the backboard was doing any good?
No, and the only reason that we did backboard her was that she complained of, it was non-specific pain all over.
Yeah, no, and I think by current protocol, you appropriately backboarded her. She was, you could argue she was neurologically acting wrong. She was intoxicated, obviously, so you appropriately backboarded her. I'm just questioning our protocol, though.
In this case, I think it was fairly appropriate. I mean, and it worked out for us that we were able to control her more on the stretcher
That's a good point.
after she was arrested and became more agitated.
Right. All right, well, great care and great finding her stashes. I'll just leave it at that. So, sedation, we do have to sometimes think about assisting somebody to protect things because they're altered by medications, or really drugs is a better word. Whether they have a femur fracture in their stirrups, wailing around, or in this case it was, she's wailing around and really not appropriately staying on the backboard and what have you. So we gave the Ativan, kind of calmed a little bit, made a little headway. So the biggest thing I want to talk about is the backboards. We've decreased use about 60% from before, but we are working on about have our finalized protocol on no more backboards. So hopefully within the next, I'll say 90 days, we'll be moving towards that. Essentially the protocol will be pretty similar to what we have currently. It's just if they have any, if they're, like in this case, this patient was acting different or intoxicated, they just get the cervical collar, no backboard. And they'll probably remove the age range on that as well. So currently we're 10 to 65, is that right? So when we look back at some of these, truthfully not everybody's following the protocol that well. We're clearing 72-year-olds and clearing 7-year-olds, and that's really inappropriate by the protocol. And so we've kind of had some discussions. Do we need to have some talks with particular personnel doing that? So no, I think we're the ones that need to have the talks with ourselves, because we just need to quit using those dang backboards. So that's what we're moving towards with that. Sound good? Anybody want to keep using backboards? So, we'll still use them for extrications, code situations. We're not going to take them off the unit by no means, but I bet we went to 60%. I bet we can get to 80 or 90 decreased use. Hopefully it'll be great. It saves time whenever, it is a trauma patient that needs to get to an OR. It's less time having to secure them to that and what have you. So is there anything else? Another slide on this one? I don't think there was.
Here's just after the call.
All right, good job. So a few things, just a couple other things to talk about. So case review requirements. So I believe we brought this up before. Right now it's written as 4 live case reviews and 8 recorded. Is that problematic? Because I was given a list of about 20, 25 people that have not met that criteria for the last few months. And, now the question is, what do we do? We've asked, does anybody think that's unreasonable? Let's talk about it. Go.
We've only had one this quarter that we could even go to on this shift, because the rest of them were on while we were on shift.
Okay. What about the recorded ones? And more of the issue, I should clarify, is it seems to be the recorded ones. People just not watching them.
That's their fault. It's provided to you. If you can't watch it, that's your own problem. It depends on which station you're at.
Well, I agree with that, especially y'all out there. But
And that's something we're
anybody in
addressing.
town.
We're trying to get that fixed.
Which problem, what station is the problem?
Modal. Abernathy, but we've gotten with the hospital with Modal. Some of y'all have used Modal before when we did the Ebola CE through the hospitals they required. And so we're working through that process to expedite that and hopefully make that a lot easier process. But besides that, all the other stations, we've been through all of those multiple times, and everything should be working properly. If it's not, we need to know so we can get that fixed for you.
And let me ask you this, like, so you watch one at the station, there's, I guess, some paperwork or things you have to do to confirm that you watched it. Does that system seem to work okay? Do people see issue with that system? So you all feel the 8's appropriate and somebody not finishing them, there's really not a good excuse for that?
I think it'd be nice to have like a monthly roster of, everything that's sent out, because, you got a couple days off and the CE drops, the staff meeting drops, you get to work, you get busy, a week goes by, and it's buried in your emails.
Gotcha.
So I think like maybe a monthly checklist, say this is everything we put out, do it on by the 30th or whatever. I think that'd be a good way to keep track of it.
Definitely do that. So I'll probably send that out, then we can start sending out maybe the first of the month. So here's April's CEs for the month. Here's what we'll be completing. And so that way you'll have that. Will that think that'll help? Okay.
I was busy. You guys get busy.
Yeah, we could theoretically look at, well, by the 20th of the month, if you didn't complete this, and send you a reminder. But my personal opinion, I think that's inappropriate. We're all professionals here. If there's something you're supposed to do that month, we don't need to be sending out reminders constantly, especially something like case review. Everybody in here knows you should be looking to do a case review every month. And if it happened to be a month, for some reason we didn't have one, then that's fine. But everybody knows every month, oh yeah, let me look into that, do my case review duties for this month. All right. The other thing I just was going to touch on is N3s with, so those are injured patients that we're doing a refusal on. The questions come up, should we or should we not do spinal clearance? It's a question that some of you guys have asked, or I shouldn't say spinal clearance, but, kind of do the spinal protocol, and I think you should. And most of the time, if the patient's not going to let you examine their back or something, they're like, no, dude, I know I've got road rash, just don't touch me, where do I need to sign? I want to get out of here, you can't do it. But we kind of compare it to doing an EKG in a chest pain patient, that ends up refusing. It just could give some more ammo to maybe say, hey man, your back's really tender, there where I was pushing it, you thought you were fine, it was real tender, you could have a fracture there, you sure you don't want to come with us? So it's completely appropriate to do the spinal, kind of go like you're doing the spinal clearance and then document what your findings were. It's more apt going to help you down the road. And if the patient refuses, I would document, patient was in a rollover MVC and refused to allow me to do this and that, and I couldn't do a spinal exam on him, and he wanted to refuse. That's what's going to help you in court.
And that's not saying that the spine's clear.
Yes.
You need me to say that?
No. I heard a little squeak out there.
Speaking of N3s, something I've seen a lot of, thought I'd discuss it with y'all. As far as documentation goes, a lot of the reports are just saying that the N3 was explained to the patient, they understood the sign. Shouldn't it be a little more specific to the dangers of refusing, documented?
It really should. If they're chest pain, you should say, I can't rule out a heart attack in the field, and the patient should go be evaluated. If it's a trauma, I can't fully evaluate if you have some kind of internal injury. Any time on any sort of refusal, the more you can put, the better. I know it's a pain in the rear. We have patients refuse in the ER, and some of those are my longest notes because we try to bolster the chart, if you will, and try to appropriately tell the patient all these things. But it's not oh, you want to leave? Okay, fine, sign this and get out of here. It's hey, I understand you want to leave, but you have chest pain and you're not letting me do this, or let me transport you. You may have a heart attack. I can't tell you whether you do or don't, and then try to document that. These type situations are ones that get you. One of the most common in the emergency medicine world, as far as in the ER, are patients that leave against medical advice. and they sue because they say that nobody explained to them what could happen. Well, you know, I knew I had chest pain, but I never knew I could go home and have a heart attack. You know, nobody explained that to me. And if you go back and look at the doctor's note, and it said, you know, patient with chest pain wanted to leave, signed AMA at 1839, then you're hosed. Hey, you didn't explain to her she could have a heart attack. Well, she had chest pain. Surely she knows that. No, that's a lay person. They didn't know that the chest pain could mean she has a heart attack. So that can come back and bite you. Refusals are big things. I know they're easy to take lightly, and I know a lot of times it's sweet. We don't have to do a big report on this, get on down the road, but you have to take them serious.
In your opinion, how many times when we ask someone, do you want to go, and they refuse, how many times in your opinion should we ask them? Because I have sat there on scene and asked them like 16 times, and they're still adamant, you know?
I mean, I don't know that there's a magic number, you know. You're probably a better man than I wouldn't ask somebody 16 times.
It was one that I knew needed to go.
Yeah,
I just never refused you.
And you know, in those, that's when I think, and we see the same thing in the ER, you know, sometimes people want to leave against medical advice. You're like, whatever, there's nothing wrong with you anyways. Other times you're like, dude, you know, you go home, you're going to be dead, or you're going to come back a lot worse off. And, you know, you do try to pull out the, well, could I do an EKG on you? And, well, this EKG's got some funny things on it. You really should come to the hospital with us. You know, you almost try to get in this bartering with them, which I know sucks and difficult, but at the end of the day, you're trying to do what's right for them. And, you know, at some point, as long as their mental status is good, you can't do it all. At some point, they just have to refuse. So, but that's the answer I like to hear. You're trying to do what's right for the patient. And it's not, oh, you want to refuse? Here, sign this. We're out of here. That's what you don't want. Any other questions? How's everything else going out there? All right. I guess we're done.